Hello. This is a video overview of Module 4A in the Advanced course in Dermatology. Tonight we're going to have a look at atopic dermatitis, and we're going to deal with some of the complications of atopic dermatitis. We'll also have a look at some aspects of dermatoscopy, clues to melanoma, colors, some other difficult structures and patterns. And we'll have a little talk on pilomatrixoma. So let's have a little look through. What are we going to be covering? Well, the questions that we'll look at in the main module webinar will be, what role does histamine have in the pruritus of atopic dermatitis? Simple answer to that is not a lot. There are many other mediators that are more likely to cause the itch in atopic dermatitis than histamine. Generally, histamine only acts as a sedative. Now, we'll go into what these other mediators are and the therapies that may be associated with them that are beneficial. You also have to know with atopic dermatitis, what are the major exacerbating factors? Now, we know infection is important, but there are so many other factors, both stress and environmental, and we'll go into a lot of these. And when you're dealing with a patient with severe atopic dermatitis, it's very important that you go through all of these exacerbating factors with the patient, looking at their history, looking at their job, looking at the way they handle their skin, how many times they wash, what else they're doing, the hobbies they have. It's one of those conditions where the more time you spend with the patient, the more time you chat to them and find out how they live their lives, the better the advice, the more direct the advice that you'll give in trying to help them control their atopic eczema. We'll also have a look at the id reaction. What circumstances does it occur? Well, certainly one of the commonest in my experience is stasis dermatitis. But we'll deal with this in a bit more detail in the main webinar itself. And then lastly, what are the causes and the management of generalized exfoliative dermatitis? Now, this picture of generalized exfoliative dermatitis, it can have a whole variety of causes, and we'll go into them. And they can include such things as lymphoma, pityriasis rubra-pilaris, psoriasis, as well as atopic dermatitis. So, investigation is important, and management is certainly important, because generalized erythroderma leads to circulatory problems in the elderly, leads to temperature regulation problems, and all of these have to be addressed. So, this video will go over all of the images that are in this module on atopic dermatitis. Certainly have a little look at some of the DermNet references that are there. Look at this issue of how the picture of atopic dermatitis varies with age. And it does change with age. It's important that you know what's common in particular age groups. So look at that section, look at it carefully. We'll mention bleach baths for atopic eczema, mainly for the type that is generalized and gets recurrent infection. Because staphylococci and colonization of the skin with staphylococci can play a major part in atopic dermatitis. And bleach baths are a fairly simple way of reducing that bacterial contamination and reducing some of these flares. There are certain complications that are associated with atopic dermatitis. Remember the immune complications associated with it, because they have defective cell-mediated immunity, means that they're susceptible to fungal infections, they're susceptible to viral, particularly papillomavirus infections. And there are other complications related to the drying of the skin. They'll develop pityriasis alba. They may get also keratosis or pilaris. So have a look at that DermNet article there and remember some of those complications. This was another little Medscape article into bleach baths, and it goes into things a bit more detail in terms of the infective element in patients who have recurrent severe atopic eczema. Watch this one, Kaposi's varicella-form eruption. That's important. Very often an atopic who develops this, it will be their first exposure to the herpes virus. And what generally happens is they come in contact with someone who's got an active cold sore, their eczema becomes infected and spreads like wildfire to all the atopic eczema. These patients can look quite ill. They are quite ill. They generally have to be admitted to hospital. So read up a little bit on Kaposi's varicella-form eruption. Or it should be herpetiform eruption. Varicella-form eruption is where the same phenomenon can occur with the chickenpox virus. The varicella virus will change that. These were just some pictures of pityriasis alba. In the module itself, or in the webinar, we're going to talk a little bit more about some of the systemic therapies for atopic dermatitis, because you're all fairly au fait with the common preparations, topical preparations that are used in treating this condition. But if you've got patients with severe atopic dermatitis, then you've got to consider alternative treatments. And that may involve phototherapy, particularly narrowband UVB therapy if that's available. But it may also involve systemic drugs. And the ones that are most often used are azathioprine, Imuran, and methotrexate. Cyclosporin is also available. This drug certainly is effective, and we'll talk a little bit more about it in the main webinar. But the main complications associated with it are hypertension and renal damage, and a low-grade risk of developing lymphoma. However, it is an immunosuppressant, as is azathioprine. So some of these patients can be more susceptible to developing a variety of skin cancers, so this always has to be taken into consideration. However, these drugs can be life-saving. Remember also that atopics in later life can go on and develop a hand dermatitis, and often it can be quite a severe hand dermatitis, and even those patients may require systemic therapy. We talked about that the last time we talked about the dermatitic process. So I said here these were the main points from this module. It presents differently at different ages. It's a disorder of barrier function rather than allergy, and that's important. It's a deficiency of ceramides. They also have a complication where in some people they have ichthyosis vulgaris and they don't form filaggrin normally in the stratum granulosum. But essentially in atopic dermatitis it's a deficiency of ceramides, the fat-like molecules that help to fill the interstices between the keratin structure of the stratum corneum, and hence they lose water vapor, and the skin's more susceptible to irritants. Remember, the other business in atopic dermatitis is the atopic march, this phenomenon of developing atopic dermatitis first and subsequently going on and developing allergic rhinitis and allergic asthma. And it appears that the allergens such as dust mite and the like that may be precipitating allergic asthma initially have to enter via the skin. So that if the skin is controlled and then this progression from atopic dermatitis to asthma is less likely to occur. So there's a lot to be said for trying to control atopic dermatitis. This business here about treatment: treat the sources of skin irritation, adequately moisturize the skin, watch for secondary bacterial and herpetic infection. We've already discussed that. This video here is actually quite useful. It's one that was delivered, I think, at one of the Hawaii dermatology conferences, and it's an up-to-date discussion on atopic dermatitis. And I thoroughly recommend that you listen to this particular and look at this particular video. Now, in Module 4A, we're going to also have a look at dermatoscopy, and I'm afraid there's quite a lot here. I've given you the introductory videos that we use in the Dermatoscopy Made Simple website, and you can go to that, www.dermatoscopymadesimple.blogspot.com, and you can see all these particular slides and videos there. But it's important you look at that. It's important you have an understanding of why you get the reticular pattern, the net-like pattern, in most pigmented melanocytic lesions. And it's because usually if there's a prominent or reti ridge structure in dermal papillae, you've only got a thin layer of pigmented cells over the dermal papillae, and you've got a column of them that you're looking at vertically with a dermatoscope on a dermal ridge, or on a reti ridge here. So these are the black areas of the outline of the net, and the pale areas represent the dermal papillae. Some places in the body, the reti ridges are in fact effaced, and that's often the case in sun-damaged skin in the face. So there, the net-like pattern that you may be seeing is a pseudo-network pattern because of the arrangement of the follicles. You're seeing the openings you're seeing are the opening of hair follicles in the face. These videos will go into this, so it's well worth looking at. And it'll look at some of the clues to melanoma. I'll actually bring this slide up because we'll come to this again later, but it's important you've got an idea when you look with a dermatoscope at what the major clues to melanoma are. And we've said thick lines reticular, or branched, especially peripherally. Whenever you get thick lines reticular, it means that there's obviously a thick column of melanocytes, perhaps even nests of melanocytes, down the sides of the reti ridges, and hence this thickens any lines, net-like lines that you see. Lines parallel with ridge pattern, that's particularly on, well, it's only on the palms of the hands and the soles of the feet, because that's where you have the dermatoglyphics that are and the physical structure that allows that to occur. Lines radial or pseudopod segmental. This again represents the growing nests of cells at the periphery of an expanding lesion. So you will get lines radial certainly in active melanocytic lesions, also in Reed's nevi, and certainly in melanoma. Grey or blue structures generally represent melanin deep in the dermis, and again are a reflection that melanoma is invasive. Grey dots, again they represent melanin in melanophages in the dermis and represent a degree of regression within a lesion. It's always something that's important. Black dots are clods peripheral. These are just actively expanding nests at the periphery. And certainly any of these dots or clods peripheral is more important because it represents expansion peripherally. They're not so important when they're central, except if the clods are of varying size. Eccentric structureless areas, we'll need to show you that later, it's something to note. White lines, these probably represent the collagen structure on which melanomas try and build themselves. But white lines can also be seen in BCCs and in, well, dermatofibromas for that matter, and the septae in certain vascular lesions. Polymorphous vessels, especially with dot vessels. This is mainly in relation to amelanotic melanoma, where you'll get different patterns of vessels, but especially if you've got dot vessels there as well. And I think, again, with atopic amelanotic melanoma, if you've got various shades of pink within a lesion, then it's important. So I've spent some time go over these. These are a very important thing to remember in looking at a lesion dermatoscopically to assess it. Business of colors. Colors are important. We've said there you'll see a variety of colors, and generally colors in dermatoscopic lesions are due to melanin, or they can be due to red blood cells and vascular structures, or the white can be due to collagen. The color of melanin depends on where it is. The higher it is, the melanin right underneath the stratum corneum or in the stratum corneum looks black. Melanin at the dermal epidermal junction is a light brown color. Melanin in the melanophages in the dermis is gray. Melanin deep in the dermis is blue, like a blue nevus. So have a little look at that video on colors. And then this one just goes over aspects, an introduction to Ketlerian terminology, which essentially looks at all dermatoscopic structures in these terms. The lines can be lines reticular, they can be lines branched, or can be lines curved. They're lines parallel on the palms of the hands and soles of the feet. Clods, circles. Circles can, if they're joined up like that, it's almost the same as a reticular network, but many circles aren't joined up like that. And there's different colors of circles, gray circles, white circles. Pseudopods, again, these are usually dot-like extensions with a base connected to the rest of the reticular network. They generally represent rapidly growing cell nests, so they're particularly seen in melanomas, but they can also be seen in Spitz nevi. So these are the things: lines, pseudopods, circles, clods, dots, and structureless. Have a good look through this video. It is important just to get a feel for this terminology. And these images go on and discuss it in more detail. There's a whole series here on the lines reticular. There's a series on lines branched, which are particularly seen in some of these diagnoses. And lines curved. Lines curved are probably the ones you're going to see most often, and these are in solar lentigo seb Ks, some congenital nevi, occasionally in melanoma. Have a look at some of the pictures there as well. These were lines lateral-peripheral. This is a Spitz nevus, by the reed nevus, by the look of it when you see that, and they often have little pseudopods as well. Some melanomas, though, if you've got lines radial with pseudopods and they're asymmetrical, then that's much more suggestive of a melanoma. Whereas if they're very symmetrical like this, then it's more suggestive of a Reed's nevus. And then a little bit on lines parallel, ridge pattern or furrow pattern. It's quite a lot in this module. I apologize for putting so much in, but it's good to go through this and look at the videos early and just get a feel for this. Because if you're taking up dermatoscopy for the first time, you really need to get on top of these patterns very, very quickly. We'll go into some of this in more detail in the main webinar itself. We're also going to have a look at pilomatrixomas. I'll deal with those and look at these various references in the main module. This is the typical presentation of a pilomatrixoma. Usually a child on the cheek, firm, and I mean really firm, rock hard type nodule there. And that's because there's calcification within these. The drug of treatment topic this week was going to be tacrolimus and pimacrolimus. These are the calcineurin inhibitors. You know, they're anti-inflammatory topicals that are non-steroidal. And they're used in a variety of conditions. We tend to, they're in here because we use them in atopic dermatitis, especially in the face. Pimacrolimus is used, but mainly to stop flaring in younger children. Rather than as a treatment for an acute flare. You use topical steroids for the acute flare, you use the pimacrolimus or Elidel to control subsequent tendency to subsequent flares. And it does lengthen the time to subsequent flaring quite considerably. We don't have tacrolimus available here in Australia unless you get it compounded. It's usually the 0.1%. Overseas it's called protopic. You can see here, though, that it has an effect on, reduces the production of T cells and cytokines that they produce. So it's useful in a variety of other disorders as well. And you'll see it there that it's listed for lichen planus, vitiligo, lichen sclerosus. They're even in psoriasis, some of these circumstances. So have a listen to this video. I will go into some of these topics during the webinar itself. Lastly, there's an interesting case that was presented of an axillary rash that you may not see terribly often, and we'll have a little discussion about that as well. So that's an overview of what we'll be doing on Monday night. If you've got time, certainly listen to this beforehand. Perhaps have a look at this video describing some of the images. And if you've got time for some of the references, have a look at those too. If you've got questions, bring them up on Monday night when we have the discussion. Thank you very much.